Hello students, today we are going to study about a topic which is very simple, but we often get confused about it. Why so? Because it has got so many nerves coming out of it. It is a plexus we are talking about, which we say it as brachial plexus. We have learned a lot about it, but whenever we try to revise or whenever we try to recollect, we are often confused about it. So let us briefly revise brachial plexus. Um, we all know brachial plexus arise from the ventral rami of spinal nerve roots C5, C6, C7, C8, T1. Ventral rami of spinal nerve root C5, C6, C7, C8, T1 in 90% of cases, keeping into concentration variation of C4 and T2. In 10% of cases, we find that the nerve or the brachial plexus has been formed by C4, C5, C6, C7, C8 spinal nerve root, and it may also be made by C6, C7, C8, T1, T2. Fine. And the ventral rami. Now, ventral rami tells us, which is ventral rami is basically responsible for the motor innervations. Now, it gives the information to the motor nerve. Now, if we see for this, just quickly, if we revise, this is the transverse section of the spinal cord, and you know this is the we say the white matter, and this is the gray matter. This butterfly shape is the gray matter. Herein you see this is said to be the dorsal horn, and this is said to be the ventral horn. The dorsal horn, the ventral horn. The dorsal horn is basically responsible for sending the information to the central nervous system. It is basically said to be the sensory route, or the afferent nerve passes through it. And the ventral horn is responsible for bringing that information to the muscle. So it is responsible for, it is efferent in nature, so it gives information from the brain to the muscles. So herein we are telling that this it involves the ventral horn or ventral rami of the spinal nerve. The spinal nerve has been formed by the dorsal as well as the ventral root. They combine together to form the spinal nerve. But in brachial plexus, only the ventral root is involved, not the dorsal root. This is a very important point. So it involves the ventral rami of C5, C6, C7, C8 and T1. Fine. Now this is the brachial plexus. Now if you can understand, it arises from this nerve root. So if I can draw this, and important part of this is just to quickly revise. Brachial plexus is formed from roots. If I can show you like this before we draw over here, quickly I will draw. Now if you can see this, it has been formed by C5, C6, C7, C8 and T1. This is how we used to learn, and you will also remember this. C5 and C6, basically brachial plexus is divided into 5 areas: roots, trunks, division, cord and branches. Root, trunk, division, cord and branches. 5 things and 5 hand. We remember it with hand. So the first two, C5, C6 is been forms the upper trunk. C7 forms the middle trunk, and C8, T1 together forms the lower trunk. So this is how it has been divided. C5, C6 forms the upper trunk, C7 the middle trunk, C8, T1 the lower trunk. Now each of these trunk is divided further into anterior and posterior divisions. Anterior and posterior divisions. And these divisions, they are further divided into formation of cords. They are further divided into formation of cords, and then the branches. So this is again, the branches are main 5 branches, which we remember in the form of Marmot, that is the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve and the ulnar nerve. So this is how we briefly used to do. Now if we can do it here, we can see this is C5, and the nerve which is coming from this, okay, let me first draw this quickly. C5, C6, C7, C8 and T1. This is the vertebra and this is how it is coming out. So this is the section. Let me show it with different. The nerve which is coming from the ventral rami. Remember, the nerve which is coming, this is a section I want to show, is coming from the ventral rami of the section of the cord. So you can see C5, C6, C7, C8 and T1. Fine. So this is, it is coming from the area. Ideally this is coming from here. I'll be showing you from here. C5, C6, C7, C8 and I'll take it from here. So this will be the formation. Fine. And this is very much important. Why it is important is there is a term which is called as preganglionic and postganglionic injury. Now, whenever the spinal nerve root they arises from the cord, they first go to a ganglion where they collect and then they divide it into further branches. Now, herein there is a celiac ganglion. They passes through that celiac ganglion and then they divide further. Now, what happens is when the injury is before it enters into this ganglion, whenever the injury is before the entrance of the spinal root in the ganglion, it's said to be a preganglionic injury. Now you understand why it is said to be a preganglionic or a postganglionic brachial plexus injury. So before it enters into the ganglion, an injury which has happened at the level of the and before it enters into a ganglion is preganglionic injury, and in this case wherein preganglionic injury takes place, the sympathetic nerve is involved. And whenever the sympathetic nerve is involved, there will be the recovery rate is very less, as well as there will be a Horner syndrome will be present. Horner syndrome is ptosis, meiosis and anhidrosis. That is, ptosis is drooping of eyelid, meiosis is complete dilatation of pupil, or you can say not dilatation, it is constriction of pupil to light as well as darkness, and then there is anhidrosis is sweating, excessive sweating to the area. So this is a typical preganglionic, and postganglionic is after the nerve passes through that ganglion, that is called as postganglionic injury, and in that case the recovery is more. The recovery is really more. So if you can see, this is C5, C6, C7, C8 and T1. Now this is an important thing. So let us now see this going into, this will form, this is roots. You can see this is roots. Now from roots we are forming trunks. Now what happens over here is that this two, that is C5 and C6 will join together to form the upper trunk. This is the upper trunk. C7 will be alone. It forms the middle trunk. C8 and T1 will form the lower trunk. Roots, trunk, C5, C6 forms the upper trunk, C7 forms the middle trunk, and C8, T1 forms the lower trunk. Is this clear? Now these are the trunks which have been formed, and after this trunk there is formation of divisions. Now division takes place. So what is division? Division is that each trunk will be divided into anterior and posterior division. We will quickly make this brachial plexus and then I'll tell you where it arises and how this moves. Now remember, this is coming, or this roots, they arise from the nerve, they arise from the vertebra, and then they passes through the scalene triangle of the neck. There's a posterior triangle of this neck which has been formed by the two, it is formed like this. It is formed like this by the anterior and the posterior, or anterior and middle scalene muscle and the base of the first rib. And herein our brachial plexus runs, as well as in between the brachial plexus runs, as well along with the subclavian artery. So this is how it arises from the from the vertebra and or the corresponding vertebra, and that passes through the neck through the scalene triangle, and then it passes. This part is supraclavicular. This part is supraclavicular, that is, it is above the clavicle. So let us complete this first. It is divided into now two parts: the anterior cord, anterior division, as well as the posterior division. So I will try to make this division so that you are able to understand more easily. Fine. Okay. So this is divided into anterior as well as the posterior part. Now even this is also being divided into anterior and posterior. So I will be trying to make this more clear to you. This is getting divided into again the anterior as well as the posterior part. So what I am trying to do is, this is the anterior part, if you can see, and this is the posterior part of upper trunk. This is again the anterior part of the middle trunk, and this is the posterior part of middle trunk. And I am again making, this is the posterior part, and if you can see, this is the posterior part, and this will be the anterior part of the lower trunk. So we have divided it anterior, posterior, anterior, posterior, posterior, and anterior part. Can you see? Now this is the part which is called as division. Now out of these, each division we form cord. Now cords, this is, you can see, the lateral cord. This forms the lateral cord. This three combines together to form the posterior cord, and this goes as middle cord, medial cord, lateral cord. This is according to the position. Herein, till here it is supraclavicle. Herein, at the level of division, it goes at the axilla, and when it enters into the axilla, it is then named as cords according to its position of axillary artery. So the cord which is lateral to the axillary artery is the lateral cord, which is medial to the axillary artery is the medial cord, and which is posterior to the axillary artery is the posterior cord. So this happens at the level of axilla. Now the cords are formed. Now after the formation of cords, it goes and forms branches. Now as you remember, the branches is, they are divided into, again there are fibers. It forms various branches, like we will be showing you here. These are the branches which have been formed. Fine. So this was marmu. Fine. So this was for the musculocutaneous nerve. This was again your median nerve. This was your radial nerve, ulnar nerve, and axillary nerve. Fine. This was in brief our brachial plexus. In brief, our brachial plexus. Now the trick to remember all this is, at this stage, at the level of this level, you should know how to make the nerve root. Like for the upper trunk, since it has been formed by C5 and C6, you should know that it has been formed by, let me change the pen, it has been formed by C5 and C6. Fine. Middle trunk, it is formed by C7. The lower trunk is been formed by C8 and T1. Fine. So you should name these nerve roots: the trunk, upper trunk, middle trunk, and lower trunk. Similarly, the cords, lateral cord, posterior cord, and the medial cord, and of course the nerves. Now if you can understand, this is lateral cord. If you can see, the lateral cord is giving the anterior branch. The anterior branch itself is giving to the musculocutaneous nerve. The anterior branch is having a supply from the C5, C6, that is the cord is being formed by the anterior division of C5, C6, that is upper trunk, as well as the anterior division of the middle trunk. So it is anterior divisions combined together to form the lateral cord. This lateral cord is then anterior division is giving further been divided into one branch which is forming musculocutaneous nerve, with that is why its root value is C5, C6 and C7, because the interior branch of upper trunk and middle trunk helps in the formation of musculocutaneous nerve. Now what is happening in the medial nerve is the lateral cord is giving a branch over here. If I can show you in different color so that it is easy for you. Now herein it is giving a branch. Now it is giving a branch of lateral cord of median nerve. It is giving a branch of lateral cord of median nerve. This is the lateral cord of median nerve, and this is the median cord of median nerve. So these both combine together to form the median nerve. That means it is being supplied by C5, C6, C7, C8 and T1. So it is the brachial plexus whole has been supplied by the median nerve, because the lateral cord of median nerve as well as the medial cord of medial nerve both are combining together, and they are that is the forming the median nerve. If you can see, the posterior cord of all the three trunks, upper trunk, middle trunk and lower trunk, forms the posterior cord. Now this is giving rise to radial nerve. So radial nerve also, the root value is C5, C6, C7, C8 and T1. Fine. Now you will remember these nerve root values and you need not mark up now, because if you remember this chart, you know how to label it, how to label the nerve roots. And what happens to the ulnar nerve is the interior branch of the lower trunk. So it is being supplied by only the C8T1. Fine. And this C8T1. So you need to remember this very clearly. Fine. Now if we come to the divisions as well as the branches of it, so let me just tell you these divisions. Now this is C5, C6, C7. C5, if you can see from here, C5, C6, C7. C5, C6 and C7. You can see I am giving this branch. C7 is the long thoracic nerve. It is basically C5, C6, C7. There is one branch which is the long thoracic nerve, and this long thoracic nerve, it is nerve root value is C5, C6, C7, and it is supplying to the serratus anterior muscle. Fine. This is very much important, long thoracic nerve. Fine. There is another which is arising from C5 itself. This is called nerve to subclavius. So that is supplying to the, it is arising, its nerve root value is C5 itself, and it is supplying to the muscle called subclavius. Fine. Then there is another which is arising from here is, that is dorsal scapular nerve. Which is having the root value of C5 and C6. Dorsal scapular nerve is a nerve which supplies the rhomboids as well as it supplies the levator scapulae. Rhomboids and levator scapulae. Now the next which is herein important is that from the trunk it is arising here. Then it is important is the suprascapular nerve. Then another nerve which is coming out is the suprascapular nerve. The suprascapular nerve is arising, and it basically supplies the supraspinatus and infraspinatus muscle. So it is also arising at the level of the cord where the interior division takes place. So it is supplied by C5, C6, C7. So you say it is supplying the supra as well as the infraspinatus nerve. Now herein you see at the level of cord, we have seen it supplies the lateral, you can see the lateral median nerve, the lateral cord of the median nerve. It also supplies the pectoralis muscle, that is the lateral part of the pectoralis muscle, lateral pectoral nerve, supraspinatus nerve. Fine. So lateral pectoral nerve, it arises from the lateral cord. Okay. This is again the lateral cord is being formed by C5, C6 and C7. Remember that. Now this is arising from here. Herein also three of them are coming out. which is nerve to latissimus dorsi, which is arising from the posterior cord, nerve to latissimus dorsi, which is thoracodorsal nerve, and this is arising. It is also giving nerve to upper subscapular and lower subscapular nerve. Upper subscapular and lower subscapular nerve supplies basically the subscapularis muscle as well as the teres major muscle. Subscapularis and teres major muscle. Fine. And here in the medial cord, again there are three major area where you see that it is medial cord of median nerve, medial pectoral nerve. Again, it supplies the pectoralis major muscle, the medial lateral pectoral nerve as well as the medial pectoral nerve. And it has got two cutaneous branches for arm as well as forearm. Cutaneous branch of arm as well as forearm. So it has got cutaneous branch. So if you remember this, these are all the in nutshell the brachial plexus itself. Fine. Now if we see the anatomy of it, now let us see through this image. The brachial plexus is arising from somewhere at the neck, at the back of the neck, wherein it enters into the scalene triangle. It forms the you can see first the roots as well as the trunks, and it is passing through this scalene triangle. Scalene triangle has been formed by the scalene interior and middle, and at the base of the first rib. If I can show you from this is the scalene muscle. So as soon as the root is coming out, it is passing through the scalene muscle, and where you can see anterior and middle scalene muscle, and the base has been formed by the first rib, not the clavicle. The base has been formed by, because it is behind. So it is formed by the first rib, and herein brachial plexus is passing through, and along with the subclavian artery. Now this part is beneath the clavicle. It is beneath the clavicle, or it is above the clavicle. It is not below the clavicle. It is above the clavicle. So this part is above the clavicle as soon as it is passing through. Now beneath or below the clavicle, it divides into different divisions. It forms different divisions, and divisions, they pass through the axilla. These divisions pass through the axilla, where they are named as cords: lateral cord, posterior cord, or medial cord, according to their position of the axillary artery. Now as soon as they come out of the axilla, they pass through a triangular space. Now if you can see over here, it passes through the triangular space, which I am not able to show you from in this diagram, but it is basically formed between the teres major, minor. If I can show you like this. Fine. If I can show you like this. This is teres minor. This is teres major. Fine. And you can see this is triceps, long head of triceps, and this is humerus. Now this is the triangular space which has been formed. Can you see? This is one triangular space, this is quadrangular space, and you can see herein there is another triceps space, or the small triangular space. You can see for yourself, herein this formation takes place at this point. Teres minor, teres major, this is humerus, and herein is long head of the triceps. So fine, this is formed, and herein you find that space. This nerve which is coming out over here is the radial nerve, which is coming out. From this, the quadrangular space is the radial nerve which comes out. Fine. And there is another which comes out is the axillary nerve. Two nerves it comes out from this place. One is the axillary nerve, and from the triceps area is the radial nerve. Fine. So if I can show you from here, that is the teres, and this is the two areas. So these are the nerves which are been coming out. And let me show you in a diagram which is more comfortable. Oh, it has been formed. If you can see from here, if this is the scapula, I have drawn it, and this is the spine of the scapula, this is the humerus. So you can see this is teres minor, this is teres major, this is the triceps. You find this space. Can you see this space? This is the triangular space. This is again a space. This is again a quadrangular space. Fine. So you can see from the quadrangular space, the axillary nerve pass out, and from the lower space, the lower triangular space, or the triceps space, is the radial nerve which is coming out, and herein we get a circumflex artery which comes out from this triangle. So it is important. You can also see the dorsal scapular nerve, how it has been supplied, the nerve to subclavius, they are all supplying over here itself. So this part which we were studying over here, that it has been supplied by the long thoracic nerve. It is C5, C6, C7 giving long thoracic nerve. It is supplying the serratus anterior muscle. So while it is passing through and it is giving supply. So this is long thoracic nerve. It is supplying the serratus anterior muscle. Next is the nerve to subclavius. It is going and supplying the nerve C5. It is directly giving to arises from C5 and is supplying to the subclavius muscle. Then when the forms a trunk, upper trunk, it supplies a dorsal scapular nerve which supplies or which gives to rhomboids. So you can see as soon as they come out, they are giving or they are supplying the rhomboids group of muscle along with the levator scapulae group of muscle. Levator scapulae and rhomboids are being supplied. Then is this it is giving supply to the supraspinal nerve, that is supraspinatus and infraspinatus. Both are being supplied. And of course the lateral pectoral and the medial pectoral nerve which is supplying the pectoralis major muscle and nerve to latissimus dorsi. So you can see the scapula is being supplied by the as soon as the nerve is getting originated, or the plexus is by the upper trunk of the plexus. So herein you see this is the cords, the roots here in the trunks, and as soon as the division takes place, they passes through the axilla, and axilla the cords are formed, and as soon as they pass out of the quadrangular space, they are already divided into branches. So in arm, they form branches. So axillary, musculocutaneous, radial nerve, medial nerve, ulnar nerve are already formed. So you should know wherein we give stimulation so that wherein our effect can be more. So some part is, you say supraclavicular, some part is at the axilla, some part is at the arm. So arm is the branches, cords are at the axilla, and you can see the roots and trunks are above the clavicle, and the division is below the clavicles. This is how the division total takes place. I want to show you another diagram. Herein you see there is the formation which takes place. C4, C5, C6, C7, C8, T1. Here it is dividing. This is the long thoracic nerve. As I was telling you, C5, C6, C7. This is the long thoracic nerve. Can you see? Fine. And herein you see also a very important thing is that nerve to subclavius. Here is, you will also find nerve to subclavius. Can you see that? Nerve to subclavius is also there. Then there is dorsoscapular nerve is there. Suprascapular nerve is also here. Can you see? 1, 2, 3 and 4. These are the branches which has been formed. Then is the part when the upper trunk divide into interior posterior divisions and they form into cords. As soon as the cords are being formed, then you see there are 1, 2, 3 branches, which is upper subscapular, lower subscapular and thoracodorsal nerve, which is a part of our posterior cord. Whereas you see the medial cord, which is giving again the branches, medial pectoral nerve, the lateral pectoral nerve, they both are giving branches, and the medial brachial cutaneous, medial antebrachial cutaneous nerve. Now this is all about brachial plexus. We have discussed in detail about brachial plexus. We have also discussed about the formation, what is preganglionic, what is postganglionic injury. Preganglionic is injury wherein surgical repair is required, where the recovery is not taking place because the sympathetic nerve has been involved, and the sign is along with the nerve, or there is chances of getting Horner's sign is also, Horner syndrome is also seen. Postganglionic injury, the chances of recovery is more depending upon the stimulation as well as the type of nerve injury, whether it is neuropraxia, that is it is compression of the nerve, whether or it is exantemesis or it is neurotomesis. In neurotomesis, surgical intervention is required, whereas in neuropraxia 100% full recovery takes place. In exantemesis, there is again grade 2, grade 3. Grade 2, the recovery is there. Grade 3, the recovery is only 70 to 80%. So it totally depends upon. And of course, in neurotomesis, there will be, unless and until the suture takes place, there will be no recovery. So let us now see the injury. Now, the important part of it is the injury. Now, in brachial plexus injury, if the injury is in the trunk, which is a very important part which I want to show, and if the injury is, if I can show you in a diagram, that will be more than good. Okay, if I have some diagram. Okay, now let us see the injury part. Brachial plexus injury. Now, if you can see, this is hanging part. Here, whenever the person is hanging for a long period of time, you know there is tethering or rupturing of the nerve root takes place. This is a very important part. Fine. So there is brachial plexus injury. Now, what is the brachial plexus injury is when if it involves the upper trunk. When it involves the upper trunk, it is called as upper trunk injury. It is called as upper trunk injury or herb palsy. Herb palsy is the name which is given in the cases of children which are born with when the neck is breech delivery takes place. Okay, and in that case only the herb palsy takes place. So let us see this. Now, when the child is in herb palsy takes place, the nerve root which is involved is the upper trunk, which is C5 and C6. Fine. And if it is C5 and C6, now what happens over here is the upper trunk is totally involved. The upper trunk involved, the positioning will be, because upper trunk is responsible for supplying scapula muscle. All the scapula muscles are being supplied over here. So there will be winging of scapula will be there. Long thoracic nerve is involved. That is a nerve to serratus anterior, and which may result in winging of scapula. And another is this: there is a typical position of the arm. The arm is in waiter's tip position or policeman tip position, wherein the arm is totally medially rotated, adducted, and forearm pronated, and the wrist comes into flexion. Can you see? Forward rotated. That is, it is protracted. The shoulder is protracted. The limb is internal rotated. You can see the upper arm redness, diminished atrophy of the hand will be there, and the wrist goes into flexion where the forearm goes into pronation. So this is the typical forearm or waiter's tip deformity, policeman tip deformity. This is herb palsy. This is said to be the herb palsy. If it is a preganglionic injury, then Horner syndrome will be positive. What is this? Is ptosis and smaller pupil. Ptosis is drooping of this eyelid. The normal eyelid is like this. This is drooping of eyelid takes place, and there is smaller pupil. That means there is completely there is meiosis of the pupil takes place, and anhidrosis is sweating takes place. So this is a case of Erb's palsy or Klumpke palsy. Herb palsy. Upper trunk palsy is called as herb palsy. The second palsy is, you can see the herb palsy when there is in the case of forceps delivery, or there is stretching or avulsion of the ventral rami which takes place between neck and shoulder, or in adults this can happen when a person falls at the head and the neck. When the person falls at head and the neck, this herb palsy can happen. Now, there is another called lower brachial plexus injury where the lower trunk is involved. That is C8T1. In cases of when the person is hanging prolonged for a long time, or when the in children when there is the arm, the descent is through arm. The arm is pulled first, then the neck. In that condition, there is Klumpke's palsy takes place. That is, the lower trunk is involved. Now, what is this lower trunk palsy? If I can see, there will be wasting of hand muscles. C8T1, there will be a wasting of forearm and hand muscles because it supplies, C8T1 supplies hand. So there will be difficulty, and it will be claw hand position where there will be weakness of flexor digitorum profundus, flexor digitorum superficialis, flexor pollicis longus, and intrinsic muscles of hand. That is lumbricals and introshei. Pad and dab muscles will be affected. That is, claw hand posture will be there because there will be, the person is not able to maintain this lumbrical position. Why so? The length of the flexors as well as extensors are affected. There will be imbalance between the two. Now these are, other than this, if we can see, let us revise these injuries. I wanted to just make you revise this. This is a very simple way of revising. The nerve to subclavius, which is C5, C6, it's subclavius muscle. Dorsal scapular nerve is C5, rhomboids and levator scapulae muscle. Long thoracic nerve C5, C6, C7, it supplies the serratus anterior muscle. Suprascapular nerve C5, C6, it supplies supraspinatus and infraspinatus muscle. Pectoral nerve, that is medial pectoral, lateral pectoral nerve, which arises from C5 to T1, supplies the pectoralis muscle. Subscapular nerve C5, C6 supplies subscapularis muscle and teres major muscle. Thoracodorsal nerve or nerve to latissimus dorsi is C6, C7, C8 supplies the latissimus dorsi muscle. Axillary nerve C5, C6 it supplies the deltoid and teres minor muscle. Radial nerve is C5 to T1, it supplies the posterior lateral arm, forearm and wrist and hand. Remember. Musculocutaneous nerve, its root value is C5, C6, C7. It supplies the biceps, brachialis and coracobrachialis. Elbow flexors will be affected. Median nerve is C5 to T1. It is anterolateral arm, forearm and hand is affected. That is 3.5 fingers. Palmar side 3.5 fingers will be affected. Ulnar nerve, where is C8, T1 nerve root, and it is medial surface of arm, forearm as well as 1.5 finger on the palmar side will be affected. Now if we see, just revise the injury. At the level of trunk, there will be superior trunk lesion, which is the C5, C6 palsy, which is waiter's tip palsy, policeman tip palsy, you can say. And second is the inferior trunk palsy, which is called as Klumpke's palsy, where there will be a claw hand. The third palsy is long thoracic nerve injury, that is C5, C6, C7 injury. If it takes place, there will be winging of scapula because serratus anterior will be involved and there will be winging of scapula will be there. We have already seen this in this diagram. This is called as the winging of scapula. This is winging of, it will be, the medial border will be protruded more as compared to the normal scapula position. It will be raised, the shoulder will be raised, that it will be more protracted. The scapula will be little bit elevated and it will be, the medial border will be more dominant as compared to the lateral border. That is called winging of scapula will take place. Whenever there is a brachial plexus injury, you have to rule out right like trunk injury, superior trunk, inferior trunk and long thoracic nerve. Then there is cord injury, that is in cases here in the lateral cord as well as the cord, axillary nerve is involved. The axillary nerve can be involved in cases of injection palsies. Fine, there is deltoid because it is supplied by the spinal nerve root C5, C6 and it supplies basically deltoid and teres minor muscle. So the person will say there will be numbness and wasting of deltoid muscles, basically the middle deltoid. Anterior, middle and posterior, the wasting is more prominent because the shoulder will be involved. The shoulder, the wasting will be very much prominent along with the teres minor will be there. Fine. And that is shoulder abduction will not be possible as well as shoulder rotation will not be possible. No abduction, shoulder abduction and rotation will be possible. What happens in musculocutaneous nerve? It has been supplied by C6, C7, C5, C6, C7 and it is responsible, it supplies 3 muscles, biceps, coracobrachialis and brachialis, which is responsible for elbow flexion. When you will go in for resisted elbow flexion, the person will not be able to do or the person will not be able to bend his elbow. So elbow flexion will be affected. Herein you can see shoulder abduction and rotation will be affected. Here elbow flexion will be affected. Herein claw hand will be there. Here will winging of scapula is here. And herein the person, here, what will happen over here in waiter's tip? The person will not be able to abduct his shoulder because in waiter's tip means what all it will be affected. The shoulder will not be abducted, the shoulder cannot be rotated, the forearm cannot be supinated, the wrist cannot go into extension or in neutral position. So all will be affected here. Now what happens when the injury is at the level of branches? Now when the radial nerve is involved. Now when radial nerve is involved at the level of axilla, it can be a Saturday night palsy or drunkard's palsy, or it can be a crutch palsy, the persons who are using crutch. Or it can be a mid-shaft humerus palsy, wherein it passes through the deltoid groove. Fine, there will be, the presentation will be wrist drop because radial nerve supplies the posterolateral part of the arm, forearm as well as the wrist and hand. It supplies the wrist and hand also. So there will be presentation of, that is the person will not be able to, triceps is involved. So all the 3 heads of the triceps is there as well as the extensor group of muscles, that is the extensors of arm, forearm is involved. Long areas, that is triceps, enconeus, extensor carpi radialis longus, extensor digitorum, extensor carpi radialis, extensor carpi extensor pollicis longus. All the superficial and the deep extensor group of muscles are there, as well as you can see the wrist muscles will be involved, which is responsible for the extensor digitorum is there, so which is responsible for the finger extension. They all will be involved, so that is why there will be wrist drop. There will be wrist drop. There will be wrist drop. All the I think 13 muscles will be involved over here. Now what happens depending upon which is the site of injury, when if it is in the case of if the triceps is saved, then this number can reduce. If whole radial nerve is involved, then whole 13 muscles will be involved. Median nerve, so the chances of in cases of supracondylar fracture, that is just above the humerus. If there is a fracture or at the carpal tunnel, or just above the or at the level of carpal tunnel, if there is an injury, then it is said to be a median nerve injury. This is called as high median nerve. This is called as low median nerve injury. In median nerve injury, if it is high median nerve injury, there will be Pope sign. What is this? If the person is asked to make a fist, if the person is asked to make a fist, he will make like this. Fine, he will be able to make like this. Fine, this is said to be a Pope blessing sign. This is the sign, Pope blessing sign is there. Fine, but what happens over here is that it is if it is the injury is at the carpal level, what will happen is this is called a medial claw hand. This will be the formation. Ask the person to make or spread the fingers. There will be medial claw hand. This is called said to be a medial claw hand. Fine, so medial claw hand will be there, and ape thumb deformity will also be a part of it where the thinner muscles are involved. Fine, the person will have a ape thumb deformity like this. He will not be able to extend. Fine, what happens because the median nerve supplies anterolateral part of the arm, forearm, as well as wrist and hand. So it basically supplies all the forearm group of muscles, flexor digitorum, that is the superficial and the deep part. The superficial part includes the pronator teres, flexor digitorum superficialis, flexor digitorum profundus, pronator teres, pronator quadratus, palmaris longus. All group of muscles are being supplied by the median nerve. This has been supplied by the median nerve. FDS, FDP are been supplied. Flexor, pollicis longus and brevis. All the lumbricals part, 2.5 fingers of the lumbricals are also being supplied. So these all are involved over here. What happens at the ulnar nerve? Ulnar nerve supplies the medial part of the arm and forearm. Now injury at the medial epicondyle or at the level of hamate. Fracture of hamate or medial epicondyle results in an ulnar injury where you form a ulnar hand. Now what is ulnar hand? Ulnar hand is this. Ulnar hand will be this. This is said to be an ulnar hand. But remember, this is the ulnar hand. This is the ulnar hand. So you have this ulnar hand deformity or ulnar claw hand. Fine. So this is the in case of injury or brachial plexus injury, what all you have to rule out. This is how you have to rule out. I hope you had an idea about brachial plexus. It was just a revision class, and I hope I'm looking forward for any more queries in the comment section. Thank you guys.